Okay. Hi, everybody. I think I'm probably the happiest person in this meeting today because this is something I was trying to initiate for many years. And, the right time comes when the right time comes. And it's my privilege to start this IH support group for patients and their family members or anyone who wants to learn more about IIH and share their experiences. And this is a combined effort by me and Gabrielle Mauro, who you'll meet in a few minutes. And this is an effort geared towards patient education. It's an opportunity for patients to learn from experts and at the same time discuss medical questions they have that should be general and based on concepts of the disease and treatments, not so much personal about their specific care, but more about the disease and the treatment options. It's also another effort to increase awareness for this disease that, as you know, it's a problem of sometimes finding specialists who understand how to approach this condition and treat it effectively. The second part, or the second arm of this effort, is is um, is the opportunity between patients to share their experiences and gain emotional support. I will be involved for the medical education aspect, which will include a presentation and questions and answers. And this is going to be on a Zoom platform like we're doing now. I envision this to be monthly on the first Tuesday of each month. And after a couple of introductory presentations from me, the next couple of months, we're going to have guest speakers from neurology, ophthalmology, neurosurgery, other specialists who have a role in the management of IIH. And every session will have a Q&A aspect. The questions will be pre-submitted so that I can combine them and screen them and discuss them at the end and try to keep them relevant to what we are presenting. And each session will be recorded and available online, at some point later, so anyone can go back and go through this again.
Correct. I know there was a question before in the chat if it's going to be recorded, so it will be online for everybody.
And you just heard Gabrielle Mauro, who is
That's me,
the
Gabrielle.
patient and family center care coordinator in our hospital, which will be in charge of the emotional support group. And I will let her discuss this with you directly right now.
Yes. Hello, everyone. My name is Gabrielle Mauro. I'm a licensed social worker. Those of you who are in other countries, hopefully similar social workers, they support patients, families in the hospital. I specifically am in a department, it's called Patient and Family Centered Care. I know it's a very long word. We do a lot in the hospital. We are a part of administration, and we work closely with our patients and families to ensure that everyone's receiving the best possible care from a patient experience point and also throughout the continuum of care in a hospital setting. As many of you know, you've been in hospitals before. It's extremely exhausting, it's confusing, it's overwhelming. So our role is to kind of bridge the gap, act as a liaison. Say you, for example, you come into the hospital, Gabrielle, I'm really overwhelmed. I'm having trouble connecting with my physician. Can you help me? Our team helps bridge those gaps so that you feel comfortable, you feel like you're getting the best possible care, and you kind of have someone, a friendly face to support you throughout the way. So what I was thinking is having an emotional support group for our IIH patients. Now, what is emotional support? So it's really to hold a group, a therapeutic group for everyone, to talk about our feelings, to talk about what we're dealing with, living with IIH. I think it's very important for everyone to kind of have someone there to listen to them and be in a group of people who understand what they're going through. If that resonates to anyone, kind of raise your hand if you're feeling what I'm going through and what I'm saying. And those of you that want to be benefited from a non-judgmental group of people who are like-minded and are having similar experiences that may work for you. Now, again, it doesn't replace having individualized therapy, and I want you all to know that. If you're struggling with depression from IIH, anxiety, that's okay and it's understandable. And I think it's important to have that one-on-one therapy as well. But as a licensed social worker, I am here to help guide you through the way and give you that platform to kind of share what you're going through. And sometimes, we don't want you to feel alone. And it could be very isolating when you're going through a condition that other people don't understand. I personally, right now in our department, I am the neurology and critical care coordinator in patient and family centered care. And I have the opportunity to work closely with our patients and families. And I found these support groups to be very helpful. So currently I do run a brain aneurysm support group. I run a stroke support group, and Dr. Patsalides, myself and the neurosurgery team and the neurosurgery administration's team at Northwell University Hospital felt that it would be important to have a group for you guys as well, because you do have that medical support, but sometimes you need a little bit of therapy as well. So hopefully you guys would be interested in that. What would happen would be Dr. Patsalides and I would hold these educational forums. You would have other clinicians joining in on that, but then I would have a separate group. And that separate group, I'm hoping to have less than 30 people. Reason being is I think that in a support group, you want to have enough time, especially in an hour or so, to discuss our concerns, what's going on with family, how are our family members impacted by our diagnoses, how are we handling work, are we able to work? So those kind of topics I would go through, and I would gauge it based off of what all of you think. So if this is something that you're interested in, certainly all of you have my email. I will send it out again if you need, and we will put it in the Facebook group as well. I thank you to shout out to Raquel Kramer over there. I see her. She's been very helpful for all of us. She is our patient partner, and she's been kind of communicating with the community. So if this is something you're interested in, I'm a big believer in it. Dr. Patsalides is. I think it's a great combination to really figure out how we're coping with our diagnoses. So if you do have questions, you could always call me. All of you have my contact info. I will base it if you're in other countries. I know some of you are in South Africa and in Ireland. So please, in Canada too, if you want to talk to me, we could always set something up. So that's it.
Excellent. Thank you, Gabrielle.
Of course.
So we'll move to the medical presentation. And I know from the questions that we received, I think a couple of hundred questions, and my expertise goes along with obviously venous stenosis and venous stenting. And I debated with myself whether should I present everything in one time or break it down into sections. And I decided to break it down because, number one, the wealth of information I want to share with you is significant, and it's difficult to put it in a 1 hour presentation even. I think everybody will be exhausted. Definitely I will be after that hour. And then it will be very difficult to have specific questions addressed after that time. So I decided to start today with the general information about IH and specific information about venous sinus stenosis, which is obviously something I've been working on for like 11 years now. And then I will address a lot of questions about that you submitted. And then the next time we'll discuss specifics about venous stenting, specifics about the procedure, about the details of selecting patients, the outcomes, the failure rates, the success rates, and then spread out the sessions like in a meaningful way, so that I can share with you as much information as I can without overwhelming anyone. And so we will start with basics. What is IIH? And this was described, in the 1897 by Dr. Quincke, who described a lot of early manifestations of different disorders. But really, it was best described about 100 years ago from Dr. Dundee. And basically, the title of his paper, this was published in the medical literature, Intracranial Pressure Without Brain Tumor, is basically the mainstay of this condition. And even today, basically, this is how a medical student or a doctor will describe what is IIH. But what Dr. Dandy moved on to say is basically what I underlined from his paper, is that we are dealing with a condition that has more than one underlying anatomic or etiologic basis. This is not a specific disease. This is a condition. This is a syndrome. This is a multifactorial, multi-etiology condition that presents very differently between different patients and has different causes. So he figured this out before the time of MRIs and CAT scans and catheter angiograms and fancy tools. He then discussed the possible explanations, and he also said, this is like almost 100 years ago, the other possible explanation of the increased pressure is by variations in the intracranial vascular bed, probably by vasomotor control. He put the idea that the blood vessels and the blood flow in the head plays a role in this syndrome of high pressure in the head. So, if it's important to acknowledge, the giants before us, and so I want to share that with you. Following up on that, this is a slide from a relatively recent paper who tries to put together in one slide the different mechanisms leading to high pressure in the head and IIH. And it's difficult to go in all of these things in detail right now, but one is that there is increased CSF being produced. CSF is the abbreviation for cerebrospinal fluid. It's a fluid within and around the brain and spinal cord that is produced and removed continuously. And the balance needs to be maintained in order to avoid conditions of either high pressure or low pressure. So you can have increased pressure in the head by overproduction of CSF or by reduced removal or drainage of CSF. The majority of CSF is removed by these structures that are called arachnoid granulations. For sake of simplicity, I call them CSF valves. The majority of these are between the CSF space and the large veins of the brain. And that's why the blood flow becomes important, because in order for CSF to be adequately removed from the brain, which is essential because it's continuously produced, the veins have to be healthy and patent. Which brings us to the condition of increased venous sinus pressure as a factor that inhibits normal drainage of CSF and leads to high pressure. And increased venous sinus pressure can be because of stenosis, because of thrombosis, like a blood clot in the vein. It can also be because for some reason there is high pressure in the chest, and which prevents the blood to flow from the head to the neck and the chest. Obesity may play a role in this. It's unclear, but it's possible, and I'll mention this later. Sex hormones, like female sex hormones, are also possibly related to impaired drainage from the veins, leading into high pressure in the veins, leading into decreased drainage from the CSF via the arachnoid granulations. And then there are other factors that are very difficult to identify and be specific about them, and these are inflammatory factors that were in the very early stages of understanding. But it's many different factors that can lead to IIH, or high intracranial pressure, and I will try to address some of them today. So when we talk about IIH, the name idiopathic implies that we don't know the exact etiology. And that is true to some extent, but the things we know today are a lot more than the things we knew 10 years ago, and a lot more than 20 years ago and so forth. So even though we still call it IIH and we still call it idiopathic intracranial hypertension, there is, and I'm one of these proponents, there is a movement to change the name, at least when we have an identified cause like venous sinus stenosis. And this is a little bit of heretic, but it is, what I believe over time, we have shown that this is not so idiopathic anymore. We now know that there are certain conditions that lead to the symptoms of high intracranial pressure, and in that case, we call it secondary intracranial pressure or secondary IIH, which is a little bit of a misnomer because secondary implies that we understand what's causing it, so it should not be idiopathic anymore. And these causes are a few broad categories like venous obstruction, specifically clotting, venous sinus thrombosis, obstruction of the jugular vein, which can be traumatic, which can be surgical. If somebody has like neck cancer and there's a big neck surgery, typically the jugular vein is removed. The jugular vein is the connection essentially between the brain and the heart in terms of blood flow. Or patients who have cardiac conditions that lead to high pressure in the heart, which again impairs the blood flow of the veins from the head to the neck to the heart. It could be conditions of decreased CSF absorption because of meningitis or because of inflammation or infection that has destroyed or scarred those granulations that we talked about. We know very well that certain medications or chemicals are related to having high pressure in the head. The most common ones, there's many, but the most common are antibiotics such as tetracycline, lithium, and vitamin A derivatives, and then certain endocrine disorders like Addison's disease. I did not put venous sinus stenosis in the category because there's a specific discussion about this later. But I think as time goes by, venous sinus stenosis will become a part of the known causes of IIH, taking the idiopathic out of the equation. You meaning my patients and the people on this forum know these things very well, but I want to present it in a structured way. The headaches is the most common presenting symptom, and it affects more than 80% of patients at the time of presentation. It's often severe and disabling, but has a very heterogeneous appearance. Every patient has like a little different type of headache. It can be diffuse, what we call holocranial, or it can be focal. It can, and this is the confusing part. And that's why I think a neurologist here, in this forum later on will be very important to have this discussion. There are coexisting headache disorders like migraine and analgesia, overuse, that can happen at the same time as the IIH. In other words, you can have headache from high pressure, but also headache from migraine and overuse of pain medication. The typical patient with the typical headache from IIH is a headache that is worse when people lie down and they wake up in the middle of the night often with headache, or they wake up in the morning with headache. And it's worse with high altitude and often like being in recumbent position or as I said, lying in bed. And in younger kids, it can present with behavioral changes and vomiting. Another common manifestation is neck and back pain, dizziness, nausea, vomiting. Pulsatile tinnitus, my second favorite topic, but essentially is a whooshing sound in sync with the heartbeat. And then the vision symptoms, blurry vision, double vision, transient loss of vision, what is called TVO, transient visual obscuration, which can affect one or both eyes. It can present it as a blackout or a whiteout of vision. They're typically brief, like a few seconds, or generally, less than a minute, even though they can seem like eternity when you lose your vision, even for a few seconds. It's the sense of time changes, and it can be precipitated by certain body movements, especially bending over. Other manifestations are vision loss, or what is called visual field loss. So losing the ability to see certain parts of the visual field, typically the peripheral part. And that's another issue. A lot of patients, none of us, or almost none of us, doesn't use the peripheral vision very much. So we don't really see what's out here. We focus on what's in front of us with a small angle. And it's possible that somebody may lose a lot of peripheral vision and don't understand it or don't appreciate it until it becomes severe. And that's one of the problems that patients have when they don't present early on. Vision can be distorted, can be what most of the patients describe as a weakly vision or zigzag vision. So basically you don't see the shapes are distorted, and eye pain is another possibility. There are criteria for IIH that were established decades ago and were revised, I think about 15 years ago. But the idea is basically that the symptoms and signs of increased intracranial pressure, this is what ICP means, intracranial pressure. No neurological deficits, no arm or leg weakness, no facial weakness, no speech difficulty, except for what is called sixth nerve palsy, because the sixth nerve that goes from the brain to the eye, goes from the brain to the muscles moving the eye. It travels through CSF. And if the pressure in the CSF goes very high, this nerve is affected. And as a result, we cannot have our eyes moving, in a coordinated way. So one will move and the other will lag, and that's when double vision happens. So this is the only what is called focal neurological finding that is allowed in IIH. Increased CSF opening pressure with normal CSF composition, and no evidence of mass, hemorrhage, structural lesion, or hydrocephalus, or any other cause of increased intracranial pressure. So the workup, the typical workup for a patient with suspicion of IIH is to have ophthalmological or ideally neuro-ophthalmological testing to assess for papilledema and vision loss, to have a spinal tap or lumbar puncture. Ideally, patient should be positioned on the left side. Ideally, it should be X-ray guided, especially for patients who have larger bodies. And the limit for pressure is 25 centimeters of water or 250 millimeters of water. So somebody asked me recently, I hear about 200 and 300. It's either centimeters or millimeters, and the millimeters are 10 times multiple of a centimeter. So 25 centimeter and 250 millimeter is the same pressure. Chemistry should be normal, as we said, and the cell count should be normal. The white count, the red count, the red cell count should be normal. And it would be great if after the spinal tap and removal of CSF and normalization of intracranial pressure, the symptoms may improve. That is sort of like a confirmation of that the symptoms are related to high intracranial pressure, and that normalization of pressure will improve the symptoms. but it's not mandatory to happen. And in reality, many times it does not happen, especially with the headaches, because as we said earlier, different headache syndromes may coexist, like migraines, tension headaches, you know, overuse of Tylenol or Advil, etc. Imaging is very important. Typically, MRI of the brain and orbits is sort of like a standard. And then the last, let's say, 15 years, patients are evaluated with some kind of MRI scan for veins. This is called an MRV, MR venogram. And we know the last decade that with the injection of intravenous contrast, the MRV is much more sensitive and much more accurate. CT venogram is another option, and there is nothing wrong with the CT venogram. I personally like the MR venogram because I think the images are more clear, especially with contrast. But CT venogram, this is a CAT scan venogram, also requires injection of contrast. They are also very good, and the only argument against them is that they involve radiation, expose the patient to radiation, as opposed to the MRV, who does not do that. On the other hand, a CAT scan venogram is done in a machine that is essentially open. It's like a donut that you go through quickly, versus the MRV requires the MRI machine, which is like a tunnel or a tight space. So there are pros and cons, but overall, it doesn't make a big difference. And these are the typical features that we see on the MRI scan. This is called what the empty sella is this white space here from CSF protruding and pressing against the pituitary. So it's an indication of expansion of CSF spaces because of the high pressure. That's another area of CSF space is called Meckel's cave, and there is right and left, and is where a nerve that is called trigeminal nerve resides. And this is another area that gets distended and dilated, that you see a lot more fluids under high pressure. So these are indirect signs of high pressure in the head. Venous sinus stenosis, this is what an MRV looks like. The brain, the fleshy part of the brain and the skull and the skin are suppressed. We don't really see them clearly, even though we kind of know where they are. We don't see details. And the veins are these white structures that we see here, the normal size of the vein. This is the tight narrowing, and then the vein opens up. This is the ear. This is the back of the head. This is the front of the head. And this narrowing is typically close to the ear. These are the findings from the optic nerves, like these are the eyeballs. This is the upper nasal area, and these are the optic nerves. And what we see here is that, number one, they are kinked. Instead of being almost straight, they have like this kink in them. We see that the white area around them, this is, again, CSF space that dilates under pressure. So this is called a perineural CSF space. And it's, again, it's fluid around the nerve. But the other thing we see is there is bowing of the posterior part of the eye. It should be, ideally, this should be coming like this way, like to complete the circle, but instead it's bowed in. And this is what the ophthalmologist will see with direct observation as swelling of the optic nerve. The optic nerve is protruding into the eye. Same thing as here, protrusion of the optic nerve into the eye, as opposed to be sort of like concave and to close the circle. So this is what papilledema essentially is. And it's difficult to measure it on MRI. It's much more accurately measured with the ophthalmological testing. Treatment, weight loss, medications, and surgical treatment. Obesity plays a role in IIH. It's unclear why, but there is a correlation with weight gain and obesity and intracranial pressure. This is because either the pressure in the head is elevated, or because there is changes in blood flow related to sleep apnea because of the obesity. It could also be because of hormonal imbalance or inflammation. Obesity is an inflammatory process, among other things. So this could be another way that obesity contributes to high intracranial pressure. Again, nothing has been proven in a way that is 100% accurate. But there are patients with weight loss have improvement of their symptoms. And that weight loss is in the range of 5-10% of the total body weight. But it doesn't work all the time. And it may work once, it may not work a second time. And in fact, many of my patients, they have normal body weight, or even if they have increased body weight, that weight has been stable for many years before they develop the symptoms of high pressure. So again, it's not one-to-one correlation between weight gain, obesity, or weight loss as a treatment, but there is some correlation, and I think we should not dismiss this, but again, it's not necessarily what will the ideal treatment. Medications, we talk about Diamox, which I think is the first line treatment. It's the medication that affects how CSF is produced, and it works by reducing the production of CSF. So if this is the balance of CSF, and because of, let's say, venous stenosis, the CSF is not removed effectively, so removal is down and production remains steady, the pressure will increase. By taking Diamox, you can bring the production down and reach a new equilibrium. There are many side effects that can be intolerable, especially the tingling in the hands and feet, GI symptoms like nausea, vomiting, like a source of feeling sick all the time. And there's also cognitive changes, like difficulty concentration, fogginess. You know this better than I do. Topiramate or Topamax is another medication that has shown benefit in some patients with IIH. It's kind of like a medication with multiple uses. It has a similar action to Diamox in terms of CSF production. It's also a headache medication, and it's also related to weight loss. So it makes it an appealing alternative to Diamox for certain patients. Another medication that is used primarily for glaucoma, methazolamide, has some use and some benefit in some patients. And then lastly, furosemide, or what's called Lasix, is a diuretic that can help, again, in selected patients. But the benefit that has been shown in studies is with Diamox, and that's not, it's a modest benefit, let's say at best, but there is a role for Diamox, obviously. And the other medications are used mostly when the side effects from Diamox are terrible. And then there's like the surgical treatments. And when is a surgical treatment indicated? Well, I think for 90% of the patients who do not present with the risk of permanent vision loss, surgical treatments should be considered only after medical therapy fails or is not tolerated. For patients who have what is called aggressive or fulminant presentation, or they presented relatively late and there is advanced risk of permanent vision loss or irreversible vision loss, surgical treatment can be offered earlier, and we need to be more aggressive for those patients. But this is not the majority of patients. The majority of patients, they have the option of medical management, and I think this is at least in my opinion, is the first line treatment. And if it fails or the side effects are terrible, we can consider surgical treatment. And surgical treatment, I put venous sinus stenting first just because this is my expertise, and I believe in this treatment. But there are others, like the optic nerve sheath fenestration, that essentially is opening, like, and is making a small incision around the optic nerve to drain CSF around the optic nerve. That helps with the swelling of the optic nerve and sometimes helps with the high pressure in the head. Usually it helps with vision, but not the rest. A shunt, either like a lumbar shunt or a brain shunt, which is the mainstay of surgical treatment for many decades now, works well. It has a lot of downsides. One of the future webinars or support groups will basically discuss the pros and cons of different treatments. So I'm not going to get into this too much today. I'm already taking more time than I thought. And then bariatric surgery has a role also for patients who have morbid obesity and no threat of, no vision loss or threat of vision loss, and they failed medical management. So there's going to be a separate discussion about the pros and cons of each of these treatments. So I'm not going to get into too much detail right now. The prognosis overall is good in patients who are well treated, especially in terms of visual outcomes. Is the minority of patients, about 10% or maybe a little more, that end up with permanent vision loss. Poor prognosis is mostly for male patients, which are the minority, high-grade papilledema or vision loss at presentation, at baseline. If somebody presents with these aggressive features, there is a high likelihood that vision may not be normalized. But again, overall, in terms of vision, most patients do well. Recurrence is possible, often associated with weight gain. Headache, unfortunately, may persist despite all the treatments, because the headache is not a single factor, is not caused by a single factor, is caused often by coexisting conditions. And controlling the intracranial pressure, in other words, normalizing the pressure in the head, may not improve the headaches or the disability from headaches. More treatment might be necessary, like treatment for tension headaches or migraine headaches or other types of headaches might be necessary even after the pressure is normal. And I have patients like that we did everything well, the vision improves, the headaches improve after stenting, but they don't resolve. And we do a spinal tap and the pressure is from 35 down to 15.
Dr. P, sorry to interrupt you. We have a question about what does vision loss at baseline mean?
This means that patients present and they already have vision loss at the time that they go to the doctor for the first time. They realize that they cannot see beyond what's right in front of them. So they have vision loss at the time of their diagnosis. So go back to the headache. So some patients will need additional headache treatments beyond the headache for intracranial pressure. And then there's depression and anxiety, often with long-term distress of IIH. Multidisciplinary approach is very important. And these are kind of like the mainstay of what the multidisciplinary team should include: neurology, neurology, ideally a headache expert, a knowledgeable person to deal with headaches beyond the high pressure headache, a neuro-ophthalmologist to assess the vision, obviously, and guide the urgency of treatment, an interventional neuroradiologist or an endovascular surgeon, essentially is the same thing, that could discuss the possibility of stenting if somebody is appropriate for stenting, and the neurosurgeon if a shunt or another surgical treatment is necessary. But these are basically the important members of a multidisciplinary approach. And then there's other members have role, like counseling for weight loss, like emotional support. For pediatrics is a little different, but these are kind of like the members that are absolutely necessary in a multidisciplinary team. So now I'm going to move specifically to the venous sinuses. And what are the venous sinuses? So focusing on, after discussing on the generalities of IIH, we'll focus the next part on the venous sinuses. So it's a really bad name for the large veins of the brain. And I call it a bad name because many people confuse this with the sinuses that we have like in our face. And I don't understand why it was ever called like that. And I think it's a bad name, but we're not going to change this now. But essentially, these are the large veins of the brain. They allow the blood to flow from the brain to the neck and to the heart. And they allow of drainage of CSF from the brain. Go back to the first slide or one of the early slides. So CSF, the cerebrospinal fluid, it's constantly produced and removed, and the balance of the production and removal is necessary for our well-being, for maintaining normal pressure in the head. And patency of the venous sinuses, patency of the large veins of the brain is important for normal CSF drainage and therefore normal pressure in the head. This is an anatomic slide. We see a skull and the veins, so you can understand what are the major venous sinuses. And on the top of the head, in the middle, we have what is called the superior sagittal sinus. It's a big vein that starts from the forehead and goes all the way to the back of the head. And this drains the majority of the blood from the brain. And at the back of the head, in the area that is called confluence, it divides into the transverse and sigmoid sinus, and there is a right and a left. So all this blood from the superior sagittal sinus and from other veins will come to the area in the back of the head, and from the back of the head, it will divide into right and left, transverse and sigmoid sinuses, which will travel into the neck and where they become what is called the internal jugular vein. So this is another, a graphic that I asked somebody to do many years ago, and this shows the superior sagittal sinus from the front of the head. At the back of the head, it divides into right and left and continues down into the neck into the jugular veins. So what is venous sinus stenosis? Is the narrowing of the veins, of the large veins of the brain, is the narrowing of the venous sinuses. Probably 95 to 98% of patients with IIH have this finding on the MRV. So at this age, meaning at this age of good quality MRI scans, a patient with IIH let's put it this way, it's unlikely that a patient with IIH does not have venous sinus stenosis. It may be moderate, it might be severe, but it will be there. And that is what led to all the development of venous sinus stenting as a potential treatment. It was these observations. Now, it doesn't mean that 95 or 98% of patients with IIH need stenting. We'll discuss this a little later. But the narrowing of the veins, and these are the locations, is basically as the veins curve and they get close to the inner areas of the inner ear, is where these narrowings typically happen. So with these narrowings, the blood does not flow freely down into the neck. The pressure in the veins builds up and the pressure in the head builds up. One thing that I get asked a lot, and actually it's not just from the patients, but from doctors, is looking at an MRI scan, where is the problem? Is this small vein here or in this big vein here? So the the fact is that the majority of patients, they don't have symmetric veins right or left. The majority of patients have one transverse sinus, either the right or the left, much bigger than the other side. So like in this patient, this side is what is called the dominant side, is the largest side. And the other side is very small and hypoplastic. The majority of the blood flow is done by the largest vein. The smaller vein, this is small by birth. This is not narrowed because of something that happened into the vein. This is small by design. So the majority of blood flow is from the largest vein, the dominant vein. And if this vein is narrowed, like we see here, you see the white area becomes very thin. This is where the problem is, because this vein is supposed to do 90% of the work of removing the blood from the brain, and it cannot do it because it's very narrowed. If this vein was normal, there was no narrowing, almost all the blood will come this way because this is too small to handle this. So the problem is the big side that is narrowed, not the smaller side that is designed to be small.
For some reason, I thought he weighed more.
And yeah.
Does he take medication right now? No.
Can you please mute? Sorry. Then we have
Moto G7, can you please mute, please?
Go ahead and hold him so that he doesn't jump off the table, okay? Dr. Jake will bring him in a minute. Okay.
There we go. I got it.
Okay, thank you. So on this is a different patient when the right and the left side are pretty much the same size, which means that both of these are equally or almost equally important. And in order to develop high pressure in the head, both of these need to be narrowed. So then one side versus both sides really depends on the anatomy, and the anatomy is very different between different patients. But if the veins are the same size, what is called codominant, the narrowing needs to exist bilaterally. If the veins are one side is much bigger than the other, then what matters is a narrowing on the bigger side. There are two types of narrowings and some subtypes, but in general, let's say two types: intrinsic and extrinsic. Intrinsic means there is a problem inside the vein. There is a problem within the blood flow into the vein. 90% or more of the time is what is called arachnoid granulation. It's these valves in the walls of the veins that are supposed to be flat, and for some reason they overgrow. And instead of being flat, they become like these big, lumpy, soft tissue areas in the vein, obstructing the flow. The other possibility of an intrinsic stenosis is a blood clot, and typically an old blood clot. This type of narrowing is very short and is fixed. Fixed means it will not change if you normalize the pressure. It will not change if somebody has a spinal tap with a lot of fluid removed and the pressure normalizes. It will not change if somebody has a lumbar drain or a shunt and the pressure normalizes. This will always be there because this is a problem inside the vein, as opposed to the extrinsic type of narrowing, where the vein, there is nothing wrong inside the vein, but the vein is compressed by the brain. There is high pressure in the head, and the high pressure displaces the brain and is pressing against the vein. This is a long segment narrowing and is reversible. If you normalize the pressure in the head, the vein will re-expand and will recollapse again if the pressure goes up. So what does this mean? What comes first? And there's a lot of questions about this. What comes first, the narrowing or the high pressure? And the answer is it depends. For the intrinsic narrowing, where the problem is inside the vein, is much more likely that the inciting event leading into high pressure is the stenosis. Because something happens inside the vein, the blood flow decreases inside the vein, the pressure goes up. In the patients with extrinsic stenosis, it's more likely that the pressure has increased for some other reason. It goes into the idiopathic category. And the increased pressure caused a narrowing of the vein. So one would ask, then why treat this? And that's a good question. Well, treatment helps because even with this type of narrowing, the extrinsic narrowing, the reversible narrowing, once the narrowing happens, then it creates a vicious cycle. It's like a positive feedback loop in a distorted way, that the narrowing was caused by pressure, then the narrowing itself will lead to higher pressure in the head, and it's a vicious cycle of events. And you can break this cycle by opening the vein with the stent. It does not mean that you are curing the problem, but what it means is that you are giving the patient a much better chance to control the problem than before. You remove the vicious cycle from the equation. You still don't necessarily address the initial event, but for a patient who nothing else works, who medical management that did not work, then now you offer them a chance for medical management to work. Again, intrinsic stenosis is the most likely cause of IIH, and is much more likely than not that the patients will do very well after stenting because you are removing the cause of IIH. Within extrinsic stenosis, something else caused the high pressure in the head, but the narrowing is caused by the high pressure in the head, but the narrowing itself leads to a positive feedback loop, making things worse. And you can improve the condition by breaking that vicious cycle. And this is what basically I just mentioned, why venous sinus stenting, because by opening the flow, opening the vein, and improving the blood flow from the head to the neck, then you offer a pathway for the CSF pressure to normalize. And it works better for the intrinsic type of stenosis, but it also works well for the extrinsic type. This is a video showing a stent in the patient's in the vein. This is the outline of the skull. This is the stent. The stent is very collapsed. It goes through a tube through the arm or the leg, and it's a very thin, think of like a thick spaghetti type of device. And watch now as it opens up. We basically unsheath the stent, and as we unsheath it, it kind of expands to the predetermined size. So from a collapsed tube, it becomes this expanded device, and that's how it looks. This is like from a patient, a video from a patient. The extrinsic type of narrowing, as we said, is a long segment narrowing. You see it kind of like starts from here, and this is the superior sagittal sinus, this is the transverse sinus, sigmoid, now into the jugular vein. This narrowing starts from here to here. It's a long segment narrowing, and this is after the stent has been placed. You see the metallic mesh, and it's a long stent, long construct, and this is the same picture after stenting. You see how much open this vein is and how much flow, how much improved flow we see now. As opposed to the intrinsic stenosis, where the narrowing is very, very short. It's a very focal area. It's not, the other patient had, the narrowing was from here to here. In this patient, it's like a very short, tight narrowing. And you see after the stent, it resolves nicely. You see the narrowing here. And after stent, there's no more narrowing. And this is a picture of the stent, like an X-ray. You see the skull and you see the stent, how it looks under X-ray. Again, the difference between different types of narrowing are important to understand. But does it really mean anything in terms of the effectiveness? And this is, the study I did a few years ago, when we looked on how do we improve the intracranial pressure before and after stenting. And we had 50 patients, and I did the spinal taps myself in all these patients before stenting and 3 months after stenting. It was in the same position, in the same technique. And the average opening pressure before stenting was 37 centimeters or 370 millimeters. And after stenting, the average was down to 20. It was a big change before and after stenting. Again, this is 3 months after stent. In the patients with extrinsic stenosis, the improvement was about 16, from 37 on average to 21, let's say on average. And in the patients with an intrinsic stenosis, the difference was very similar. It was a little higher, like 1 more centimeter of water, but not dramatic difference. So even though conceptually anyone would think that why treat the intrinsic stenosis, so why treat the extrinsic stenosis, I'm sorry, since it can be a consequence of high pressure. We have proven that it actually helps. Again, it may not necessarily address all the problems because there is a likelihood that there's something else that caused the high pressure. But I am sorry, I got an emergency call, sorry. Even with the extrinsic stenosis, there is a high likelihood of improvement, even if medication would be necessary down the road. We looked at that very well. Like, was this effect because the patients lost weight? Is it because between the 3 months between the procedure, like the spinal tap stenting, and 3 months later, is it because the patients went on a diet and lost a lot of weight? And is that why they felt better? And actually, on average, the patients actually gained weight. These 50 patients, we had their weight before and after, and it was on average 1 kilogram higher weight. And the majority, actually 20 patients, they gained between 1 and 13 kilos. 10 patients lost between 1 and 4 kilos. And 20 patients, they really have no major change. So it was not the weight that made this change in the pressure. And then we looked at the Diamox dose. We looked at the medication. So before treatment and 3 months after treatment, there was a 70% decrease in the need of Diamox on average. And as I alluded to before, the decrease was higher for the intrinsic stenosis patients, 80%, as opposed to the extrinsic stenosis patients, which the decrease was 60 or 62%. What this means is that it's much more likely that by doing stenting in an intrinsic stenosis patient, you take care of the problem, versus in the extrinsic stenosis patient, you help, but it's a good chance that some medication might be necessary even after stenting. We also saw how many patients were completely off Diamox at the 3 months. And in the intrinsic group, it was 80% of patients were taking no Diamox at 3 months. And in the extrinsic group, again, it was 62% of patients were completely off Diamox. So the rest required some Diamox. But again, even in the extrinsic group, the majority of patients was off Diamox at 3 months. So there is a rationale to treat both groups of patients, both types of narrowing. But yes, the intrinsic narrowing patients will do better. And it's already an hour into this, and I was hoping to discuss a little more, but I want to get to the questions. I don't want to not address a lot of the questions that I can. And I will also say this briefly. Is venous stenosis associated with other conditions? Obviously, we talk about IIH. It can be associated, and this is kind of like another big area of work and research for me, like pulsatile tinnitus without patients who do not have IIH. This is one of my next big projects, patients who have headache syndromes from venous stenosis without having IIH or high intracranial pressure. And this is a big area that is not being addressed today. And we have the chance to discuss this again. And sometimes patients can have venous stenosis on their scans and have no symptoms. I think this is relatively infrequent. The majority of patients who have venous stenosis, they do have one or more of these. And I want to mention here specifically for pulsatile tinnitus, a study I did, I finished the study just before the COVID crisis. In patients with debilitating pulsatile tinnitus, there was resolution or near complete resolution of their pulsatile tinnitus. It was 98% chance that with stenting, it will resolve completely, 93 would resolve completely, and 5% would nearly resolve. And these are patients with venous stenosis, no evidence of IIH, and no evidence of high intracranial pressure. And to show that venous stenosis, and the point of this is that venous stenosis should be considered, and it's going to take years to get to that point, but I have my strong opinion, is that it should be considered a disease by itself. It should be considered a condition that merits multidisciplinary care, and different patients have different needs and different symptoms, but the diagnosis of venous sinus stenosis should necessitate workup and evaluation. It doesn't mean that, again, it doesn't mean that everybody who has narrowed vein on an MRI scan needs to have a procedure to open up the narrowing of the vein. Absolutely not. It requires, though, meticulous workup and establish which patients will need medication, which patients will need just follow-up, and establish a plan for follow-up. I cannot tell you how many patients I've seen over the last 11 years that I'm dealing with IIH, that they would come and tell me, I've had these problems for like 12 years, 15 years, 8 years, whatever it is. And I saw an ophthalmologist and told me everything is okay. Or I saw a neurologist and told me everything is okay. Or my primary doctor did MRI scan and told me everything is okay. The most important thing is to have a team that will understand the problem and help you have a plan. If immediate treatment is not necessary, or immediate treatment is medical management, there should be also a plan what to do in 3 months, in 6 months, in 20 years. And if they don't understand, if you don't have this team, unfortunately, you may reach a point where the opportunity for good treatment with resolution or minimizing the chance of disability from vision or from headaches, it might be too late. So, and this is a plea not to the patients, it's a plea to the doctors primarily, to figure out how to identify these patients and have an organized care. Today, if somebody has, let's put it this way, somebody has back pain and has a small herniated disc that does not need emergency surgery, knows to see a physiatrist, the pain management, the neurologist maybe, but it's established what to do. If you have headache and an MRI scan that shows no tumor or stroke, but shows venous sinus stenosis on the MRV, there's a good chance I would say, okay, there's nothing to do. Bye-bye. Your vision is okay. There's no tumor. That's it. Nothing to do. And that's wrong. I mean, this, the patients know this, but that is something that needs to change. And the only way for this to change is better awareness for the patients, increased awareness for the physicians, and organized centers which involve multidisciplinary approach. I will have a sip of water.
I'm going to interrupt you quick, Dr. P.
Yeah.
I see everyone, and thank you all. We appreciate you all staying on, and we're grateful that you trust all of us. There's been a lot of questions throughout the chat room area. Unfortunately, we're not going to be able to get to all the questions today. Dr. Patsalides and I received a lot of questions. I did touch base with Christian, who is our administrative director for neurosurgery, and he's going to send me out the link for appointments with Dr. Patsalides. And perhaps this might be the need to kind of request an appointment with him, because a lot of you are sending out some very specific questions, number one. Number two, someone, Sabina, sent a very nice message about asking for resources and about other disciplines. We are on our end, on neurosurgery's end actually, they are going to be developing a website that's up currently, I believe, and should be added more information soon. So you guys will have more info through Northwell on which disciplines you'd be working with, not just Dr. Patsalides, but his nurse practitioner, myself, and whomever else is a part of the care team. So that was a very, very, very good comment someone made. Okay, Dr. Patsalides.
Yeah, it's impossible for me to look at the chat and talk at the same time.
Yeah, if you just go to the bottom, you could see it says chat.
I'm happy to, I selected some questions that were submitted by email, and I'm happy to, I'd love to do this ongoing, like send me the questions, send them to Gabriella, actually.
Yep, send me emails. Yep, anyone who wrote in the chat room, please copy and paste it and email it to me, because they're very important for us to have a long list, a list that I made for Dr. P, but it's a lot of questions, and I know that time is of the essence and we can't get through all of it, but he'll definitely combine it accordingly.
And to go back to the multidisciplinary center, we do have a center in our hospital with all the specialists, and actually the website just went live yesterday. I did not really put it up yet, but I'll do it at the next webinar, or maybe Gabriella can email it to patients. But it's all basically the elements that I mentioned, like neurology, neuro-ophthalmology, myself, cranial neurosurgery, etc. I will go to some of the questions, and I promise I'm going to stop at 6:30 because I think everyone's going to be tired by then. And I hope you realize I'm very passionate about this, and I'm very passionate about not only the disease, but patient education. And I learned to respect the IH patients for two reasons. One is that because many of them have suffered without anyone listening to them. And the second is that when I started these clinical trials at, many years ago, 10 years ago, patients trusted me with new treatments. Patients trusted me with things that have procedures that have not really been done before in a wide or in a systematic fashion. And I took the initiative to study stenting and these procedures related to stenting in a systematic, organized fashion with the FDA, with like oversight from research institutions. And it takes a lot for a patient to trust a doctor for a new treatment. And this is something that something that made me a better doctor. So I have a big passion for patients like you. So can weight loss and taking that already alone So let me just get out of here. Put the patient in remission if they have been told that they have stenosis, or is the stent placement the absolute best option? I'm just copy pasted from emails. So weight loss is an option, and taking a diuretic or another medication is an option. Having stenosis, that does not mean that the stent is absolutely necessary. I want to be very clear about that. The stenting is necessary when medical management fails or is not tolerated, or when the progression of the disease is so rapid, especially in terms of vision loss, that something has to be done quickly, something aggressive. So I hope this is clear. And if you have bilateral stenosis, is stenting the only treatment option? It's the same thing. No. Medical management first, stenting if medical management fails or is not tolerated. Does it matter if the stenosis is buildup of CSF pressure or already caused by IIH? And then the second question is, some places recommend a lumbar puncture to drain to normal pressure, and then do a CT venogram to see if the stenosis has lifted. Does this predict outcomes? So it goes back to the two types of narrowing, intrinsic and extrinsic. And the idea of doing a spinal tap and then repeat the CT venogram is to confirm whether the narrowing is reversible or extrinsic, as we discussed. It does mean that the outcome, again, the outcomes are a little better in the intrinsic population. But if somebody has reached a point where a surgical treatment is necessary, the extrinsic narrowing type of patients will also do well. So in my practice, I don't do this. I don't think I have shown over many years that both patients do very well. Both groups of patients do very well. So I don't think that this is absolutely necessary. It's not wrong. Don't get me wrong. This is not a wrong way to approach this. But in my practice, I don't do this. I did this in the beginning, in the first couple of years. And then I felt that this was not really changing the management of these patients. IIH is very uncommon for general practice providers. How do you recommend a newly diagnosed patient? This is a big issue. And how can patients advocate for themselves? And in big, in cities with a lot of major hospitals, there's a good chance you'll find somebody who knows what IIH is, but also a good chance that you're going to find one specialist who will see focus on his or her own expertise, and then say, well, there's nothing for me to do. Vision is great, or your headaches are not so bad, or the opening pressure is 22 and it's not 25. And that's a big problem, because you can find a specialist on IIH, but if things are not, if not all the boxes are checked, it may be difficult to kind of advance the care and have long-term care. And that's why I think it's important to find the centers with a cohesive multidisciplinary team, because in these centers, at least I can talk about me and my colleagues, we are not like purists. Oh, the opening pressure is not 25 and it's 24. It's really, the difference is like nothing. Or the vision is okay, but the headaches are bad, go find a headache specialist. No, we want to basically approach each of the patients in a way that we understand the issues and we understand how to help. And again, it's the minority of patients that will have surgery or stenting. The majority of the patients I see, they don't need me per se as a surgeon, but they need the guidance and the team care. So I think you have to use peer-to-peer information and the patient advocacy groups and internet. And I think that's the best way to find who the group of physicians to help. Are there differences between CT and MRV and CTV? We talk about the radiation exposures. I don't think there's any difference on picking up the narrowing between MRV and CTV or the type of narrowing. I think they're very comparable as diagnostic tools. And there is some physician preference of one versus the other. I would say that 10 years ago, MRV was not as great in terms of resolution and sensitivity. That has changed over time. The last many years, MRV scans tend to be very high quality, especially if contrast is used. So I don't see a reason to specifically do one or the other. I think it's a relative decision. If symptoms point to IIH, but MRV and CTV are unremarkable, does the patient need to have an invasive angiogram? Big no. If there's no narrowing on MRV or CT venogram, unless there is a suspicion for another vascular lesion, like a vascular malformation, an angiogram is completely unnecessary. It will not show a narrowing that was not seen on the MRV or the CTV, unless, of course, the MRV or the CTV were misread, which happens a lot, as you know. But especially, as I say, if somebody comes to me and shows me, the MRV and the CT venogram, and there's no narrowing, there is no reason to do an invasive procedure because there will be no narrowing. So again, the only rationale for an angiogram would be to evaluate the degree of stenosis. We're going to talk about this next time. And also to exclude another vascular pathology, which is very rare in the IH population. If symptoms point to, sorry for the typo here, IIH, I think I just mentioned this. So somebody suggested to put the jugular vein when there is tinnitus on the left ear, and the pulsatile tinnitus stops. Why does this happen? Because when you press in the neck, you compress the jugular vein, and you stop the flow from the vein called the transverse sinus and sigmoid sinus that go by over in the head down to the jugular vein. So when you stop the flow in the vein, you stop the reason for having pulsatile tinnitus. Obviously, that's not a good permanent solution, but it confirms that the pulsatile tinnitus, the whooshing in their ear, is because of the narrowed vein. So all these questions, don't get tired reading them. Essentially, what is going on in IIH research today? Well, not much. There is a study that we have for a new stent that is a national study, and I'm leading it. I'm going to start the study probably sometime next year. We're getting organized. It's a lot of work to compare stenting versus Diamox from early on. And there is another study that is comparing stenting with shunting, which seemed like a good idea a few years ago. I think most patients now, if they are told that they're good candidates for stenting, will not go for shunt. So I don't think that's a study that is going to be successful in enrolling patients. But I think the next frontier, instead of stenting, is new stents and compare stents with medical management. There is some research in Italy about headache syndromes and venous stenosis. And there is research like, lab type research about hormones and inflammatory markers with IIH that I think they will take a long time to kind of like reach, the medical care as we understand it. I think this is really in the very early stages. For those with hypoplastic site on a CT venogram, but no obvious stenosis, there is a precedent for stenting the narrow vein when the symptoms are only on that site? Big no, absolutely not. This will not help, and it's actually more dangerous trying to open up a hypoplastic vein, a vein that is designed to be very small, trying to open it up with a stent or a balloon or both is actually, the risk is significant to cause problems. So my opinion, absolutely not. Can he discuss arachnoid granulations and why they become larger? I think they become larger for two reasons. It's an inflammatory process, not well defined, maybe obesity, maybe an infection, maybe an inflammatory, like an insidious process, like a clotting disorder or a hormonal disorder. The other possibility, and this is mostly for the non-IIH patients who have stenosis and they have pulsatile tinnitus, is almost always young women, 20s to 30s, 40s years old. And I think it's a hormonal trigger of female hormones. Again, I don't really understand this more than that at this point. I'm not sure if we're going to have an answer in the next many years, but the trigger for the arachnoid granulations to enlarge is a combination of a hormone or inflammation. It can also be a consequence of drainage of CSF in a weird pattern, but it's difficult to understand why this would happen in somebody who's like 25 or 35 years old and it did not happen earlier. So I think the majority is a hormonal and inflammatory process. Okay, nickel allergy. I will address this a little more in the next session when we're going to focus on stenting, but I can tell you that I am not terribly concerned about nickel allergy because it's a very common problem. And it's the nickel allergy, the skin allergy is not necessarily the same process as the allergic reaction of a medication or food or something that goes into the bloodstream. And we know from literature from cardiology primarily that a lot of patients with known nickel allergy had coronary stents because of emergencies and nothing happened. So it's a complex discussion, but as a sort of like bullet point, I would say that there is it's not an absolute not. It's possible to have a stent. All stents that we know today, they have nickel. So it's impossible to have a stent without nickel, but it's also possible to have stenting despite having nickel allergy. I'm not going to the other end and say, don't worry about nickel allergy and get your stent. That's not what I'm saying. But what I'm trying to say is that after careful consideration and discussion is possible, because there's a lot of evidence, like good quality evidence, that the skin reaction to nickel does not necessarily mean an allergic reaction when you put the stent in the vein or in the coronary artery or anywhere else. So I hope that kind of like gives an idea of, and this is, I think, hopefully is the last question because it's already 6:29. Many in the Facebook groups mentioned ear pain, but I said in the past that this is not a symptom of IIH and accepted I was wrong. I think it's possible to develop ear pressure or ear pain because of the narrowed vein in the head. I accept, the how can I say, wrong opinion of the past, but my experience now is significantly higher than experience like from years ago. Just to put this in perspective, I've treated approximately 400 patients with venous sinus stenosis at this point, and I've seen every different iterations and complexities. And I do acknowledge that because of the venous stenosis, you can change the venous drainage in the area of the ear and have the pressure/pain in the ear. I don't know a specific way to treat this, but I understand that this is real. So with this, I want to thank you for tolerating for about an hour and a half. I could go on for many more hours, but I think it will take out from focused messages and patients' ability to, comprehend the issues. This is going to be this is the beginning of a series of patient-centered discussions, and the next one. This is my contact information, my phone, office number, my email, and a website with patient information. And next time I will have our own patient center available for patients to see. And the next discussion is going to be on May 4th. We're going to talk about venous sinus stenting, specifically the procedure, the approach, the risks, the benefits, the failure rates, and how it compares with other treatments. So this will be the focus of next, now that we exhausted the venous stenosis aspect. And on June 1st, we're going to have the third one. We're going to focus on pediatric patients and venous stenosis. A lot of questions about CSF leak, cyclic ICP changes, and I will address everything I understand, and I can tell you it's a elusive area that requires a lot of work. And we'll also discuss jugular vein stenosis. This will be on June 1st, and then we go from there.